I hope you found a decent lunch, giving you enough energy for the discussion for this afternoon. Welcome back. Session 3, reporting and evaluation of predictive performance of the PBPK model. We have 4 presentations before we go into the discussion and asking the clarifying questions. First presentation will be given by Sue Cole from the MHRA. Go ahead.
Okay, well, we're just going to start off really with giving you some thoughts on what we see at the moment in the submissions that we get in terms of evaluating the predictive performance of the model. And we've touched on some of this already this morning. So we have to say that the standard of reporting of models is highly variable. So what I'm going to say doesn't apply to everything that we see, but the reports that we get, some are very long, lots of data, some very little. Sometimes we don't even get a report at all. We've already discussed the lack of qualification that we tend to see, so I'm not going to go into that again. But really what we're looking at here is, how predictive is the data, how predictive is the drug model? And we've talked about this. What is adequate in terms of precision? Often they say, yeah, we've done this simulation, there's the observed data, there's a graph, they look the same. And we've already talked about, can we put some numbers on this? Is it twofold? I mean, what we say in the guideline is really that it should be done on a case-by-case basis. So you should look at the drug, what it's trying to do. If it's around the drug model, you need to look at it in terms of what you understand around the exposure efficacy relationships and exposure safety. If it's a narrow therapeutic index, then twofold is probably too much. So, and the parameters that we look at to describe the curve really depend on what the scenario is that you're trying to predict. But we do tend to focus on the parameters AUC, Cmax, and the elimination half-life. We generally see a lack of investigation of the uncertainty in the model parameters, and I'll talk about this more on the next slide. There could be identifiability issues, and Masood talked about this. So, and I agree, it probably is where you're using the model to actually define the parameters, to fit the data and define the parameters. But we see that quite a bit, or actually used to optimize those parameters. And we did have one example, which was a time-dependent inhibition of 3A4, where the Vmax for 3A4 and the K-inact parameters were linked, and it was very difficult to define one without the other. And we had to ask them to go back and generate more in vitro data to determine your Vmax, and then we were able to solve that one. And the expected variability is not always well captured in the models, and I'll explain this as well on a slide. So in terms of characterising, we want to characterise the level of confidence, and this is what we've said in the guideline. So we need to investigate the uncertainty in the parameters, and this may be in the system parameters or the physiological parameters that aren't well defined, or in vitro parameters that are highly variable. We talked about that, or where you get different results when you run the assays. And one way of investigating these is to use what we've been talked about, sensitivity analysis. And I agree, maybe you don't want to do that for everything, but then there is this global sensitivity analysis as well. And we thought it would be useful to have somebody to talk through this methodology for us, and hopefully other people here as well. So we've got Leon doing that later on this afternoon. So, but when you've quantified what your uncertainty is in the model, you need to put that into some sort of context. And there again, you're considering the concentration effect for efficacy and for safety. So the variability in the profiles, you have your populations in the softwares, and that represents the range that you would expect in physiology and in metabolic parameters you would expect in a population, and this gives you a range. And often what we see is people have done maybe 10 trials of 10 subjects. You could argue this might not be enough. Maybe people should be doing more. Sometimes we see more, sometimes we see less. But also as well, you then get a profile and you get your range in the population. but this doesn't always capture the variability. So what's missing is the sort of residual variability you get from a population model, which I agree is different because that's based on the actual clinical data. But what we've seen in a couple of applications is where people have included an additional variability term to account for this additional variability. But it's not based on anything mechanistic understanding or anything like that. It's just an arbitrary value that people say, yeah, and you'd expect that there might be another 20%, so we'll add that on, and then our observed data falls within our confidence intervals. So, that doesn't seem to be an ideal. So what we thought is, can we have a discussion about, is there a better way of informing that range based on the uncertainty that you know about your model? So I think that was all I was going to say, and like I say, the other presentations will elaborate more on this as well.
Thank you, Sue. One question, clarifying question for this presentation? No, not yet. Then we go on with the second presentation. Will be given by Ping Zhao from the FDA.
Thank you, Ian. Good afternoon. It's a great pleasure to participate in this meeting. And I'd like to first thank the organizer, the EMA, for the kind invitation. And the title of the presentation is the application of physiologically based pharmacokinetic modeling to support dosing recommendations, the US FDA experience. The views expressed in this presentation are that of the speaker and do not reflect the official policy. The next slide, as you can see, in 2014 in London at the MHRA workshop, we presented then the cumulative experience of PBPK review by the FDA. The majority of the cases are related to drug-drug interaction or DDI. This is followed by pediatrics and then some other applications. As of August 1st, 2016, the total number almost doubled, as you can see, and the overall distribution among the major applications remain largely the same. Again, majority related to DDI, and pediatric ranks the second. The same data set in our knowledge base, review knowledge base, can be viewed in a different way or analyzed in a different way. For example, on this slide, we looked at the data by focusing on the cases where PBPK have been used to support dosing recommendations in the US prescribing information or the US label. In total, there are 38 cases in the same period of time from 2009 and August 2016. When you look at this distribution at the bottom of the slide, DDI is predominant. You have like 32 cases with DDI or DDI with other intrinsic and or extrinsic patient factor. And there are 2 cases of pediatrics and 3 or 4 cases with oral absorption in general. Then let's take a look at the current status of predictive performance of PBPK in various applications. As I mentioned earlier, there's a predominant appearance of DDI in PBPK submissions, and this seems to be consistent with the highest level of confidence for this particular application or intended use of PBPK. And if you go down the list of this table, the confidence level decrease. For example, cases related to DDI with regard to the involvement of drug transporters, specific populations such as the impact of organ impairment and pediatrics on the PK and age on the PK of the investigational drug. And at the bottom, there are other cases where there were very limited experience. And the decrease in confidence on the right-hand side of the slide seems to be related to higher reliance of system knowledge, as many of the earlier discussions have alluded to. So in order to evaluate whether a predictive performance have been demonstrated, especially for this case of predicting the effect of enzyme modulation, the question can really just be focused on, can PBPK prospectively predict the effect of CYP modulation? And through the past several years, we have published several regulatory research reports focusing on this type of data. And the first one was published in 2014, which looked at the use of PBPK to predict the effect of co-medication and or genetic polymorphism on drugs that undergo multiple clearance pathways. In this case, it would be 3A and 2D6. And then in 2015, we reported an analysis of FDA submission. Again, this is based on the database that I mentioned earlier. So you have to sift through the applications and then to identify cases where you can really do this kind of predictive performance analysis. And this second analysis focused on the effect of CYP P450 inhibitors on substrate drugs. And then the third one focused on the effect of CYP3A inducers, because the 3 induction is most commonly evaluated pathway for enzyme induction. The next slide gives you the high-level findings comparing all the 3 studies. We used this R value, which is predicted exposure ratio, AUC ratio, or Cmax ratio, versus observed exposure ratio as the evaluation matrix for the predictive performance. And again, the second column is an in-house analysis where we look at 4 substrate drugs. Models were developed by the fellow at FDA. And the second study and the third study by Wagner and al., they are purely focusing on the submitted cases, so that we can evaluate the same question from a different angle, that we are not biased by our own modeler, what our own modeler has done for the research. If you look at the bottom part of this table, it appears that when we apply a very stringent arbitrary prediction boundary of 80 to 125, which is similar to the BE criteria, more than 70% of the cases, the PBPK model predictions can prospectively capture the observed DDI finding. And for induction, the numbers are also more than 70%, nearly 80% of the cases. So this is a very robust prediction. And when you widen the interval to twofold, that is R value between 0.5 and 2, all the inhibitions were described within this boundary. And there's some improvement for induction, and there's some remaining cases where the induction was predicted outside the twofold boundary. And there are some discussions around this particular sub-application of DDI prediction. So overall, we can, based on these analyses, we can conclude that the predictive performance for this intended use has been demonstrated, and one can really follow this high-level workflow to predict the untested scenarios of DDI and use the PBPK simulation to support dosing recommendations. And briefly, this workflow starts with construction and verification of both substrate model and modulator model, and there are some detailed aspects that one have to pay attention. And then one can conduct initial simulations in the absence of any in vivo DDI finding, and use the simulation to prioritize, plan, and design the critical study. So for this box, you can actually imagine it's similar to the case where there's a medium impact or low impact, as the EMA colleagues have put into the guidance. And then once the critical study outcome becomes available, you can verify the model and modify the model if necessary for the substrate drug. And then from that point on, the prediction of the effect of other CYP modulators or another dosing regimen prediction, such as a multiple dose scenario, can be predicted using the PBPK models, and the findings can be used to support dosing recommendations, including the recommendations in the label. I'll just quickly go through the next two slides. One example, iligulstat is a drug approved in 2014 for a rare disease, and it was granted a priority review in the FDA NDA review process. The drug is metabolized by CYP2D6 and 3A. Under a linear condition in vitro, CYP2D6 accounts for 80% of the metabolism, and CYP3A roughly 20%. One thing need to be highlighted is that the drug has a very high clearance. The hepatic clearance is close to, and the total clearance is approaching the hepatic blood flow. It demonstrates nonlinear PK, which can be ascribed to time-dependent CYP2D6 inhibition. And there were two clinical drug-drug interaction studies being conducted with the strong 2D6 inhibitor paroxetine. AUC increased by nearly 8-fold. With the strong CYP3 inhibitor ketoconazole, AUC of iligulstat increased by 4-fold. And there's a pharmacogenetic effect being identified when comparing the AUC in poor metabolizers with AUC in extensive metabolizers. And this ratio is about 8-fold. Seems to be consistent with the paroxetine finding. And then the questions are, what are exposure changes with various CYP inhibitors in subjects with different CYP2D6 genotypes? And long story short, the applicant developed the PBPK model, and there were quite a few back and forth communications between the review team and the applicant with regard to the prediction, and some additional dosing scenarios were explored and communicated back to the applicant to conduct additional simulation. And in the end, upon the approval of iligulstat, several DDI scenarios have been predicted, and the findings being included in the drug label, which are shown on this slide. It's a little bit busy, but you can focus on those with a check mark. For example, for dosing recommendation in extensive metabolizer and intermediate metabolizers, the use of a strong or moderate CYP2D6 inhibitor concomitantly with strong or moderate CYP3 inhibitors are contraindicated. So all these based on the simulated finding. Moving on to relatively newer territory in terms of predictive performance, the question can be generally asked is whether predictive performance have been demonstrated for other applications. Here I just use the next two slides to illustrate our current thinking around pediatrics. And the question is current workflow adequate? This workflow is actually reported in 2012 in one of the earlier PBPK research projects. So it started with developing and verifying the model in adults, and before the model can be applied in conjunction with the system-dependent parameters or pediatric population model to predict drug PK in pediatrics. And you can use this learn, confirm, and predict cycle to apply this methodology. So question is whether this workflow is adequate. But if we focus on the so-called high impact area, the question can be extended to whether this pediatric prediction paradigm is able to inform dosing in pediatrics without conducting a PK study. We can conclude at the moment is that because there's a large reliance of system information for such kind of prediction, even though you can have the most adequate model in adult, verified and developed in adult population, you still need to be cautious about this kind of prediction and use of prediction value to support subsequent dosing recommendation without any PK study being conducted. This next example is one of the examples which made it into the label, but it's a kind of a double-edged sword example, not as positive as Ilikulu said. So for this drug, the applicant developed a PBPK model to support the dosing in heart transplant patients less than 1 month of age. What's being concluded by the review team back then was that due to the uncertainty in model predictions for neonates in general, the valganciclovir is not indicated for this age group. So there's still some room to improve. Then, as I mentioned earlier in the previous session, it made all these exercises may prompt us to think in the direction where we may have to subset our thinking by narrowing down the focus. For example, if it's intended purpose for pediatric PK prediction, what do we mean by that? So maybe we should really focus on some low-hanging fruits. So as illustrated by this particular publication just came out last month, this paper looked at the predictive performance of PBPK and population PK modeling of renally cleared drugs in children. So extending from what we know nearly 10 years ago, published by the software developers, this really focused on very narrow area, which is renally cleared drug. And as you can see, but at least based on this publication, the confidence is relatively high compared with what we have seen previously. So that the question is whether we're on the path of giving more detailed recommendation for some particular applications. So in summary, PBPK analyses are routinely submitted to the FDA. Confidence varies depending on the predictive performance for intended use. It is important to establish confidence in physiology so that we can more effectively use PBPK in general. With that, I'd like to take any clarification questions.
Thank you, Ping. One question for this moment. Yes, Eva.
Thanks. So I just had a question related to the use of data on precision when you're looking at a particular application. So for example, here, when you are looking at your data on inhibition and induction, and you were showing us that you had a certain percentage within 80 to 125, and then the remain were up to 100 or a doubling. Do you then use this data on the precision when you are looking at an application? Do you think about the uncertainty in your result of the simulation when you're going to propose a labeling? And the same thing here, because, for example, when you are looking at 3A4 inhibition in 2D6 PMs, that will be very dependent on the small pathway that is still there, what will be the actual fold increase in exposure. Do you also take uncertainty into on that parameter into account when you make like labeling recommendations?
Yes, absolutely. So for first of all, for the alternative pathway, in a given application, we definitely interrogate the presentation of the model, in terms of justification and assumption on why a small pathway is not included, or sometimes people just use this 5% with a not specified, mechanism not specified, and then in the end, I think again I see that as a purpose within purpose. So the bigger purpose is prediction of CYP modulation on NME, and now with all these data, we have very good confidence. So if a similar case come to us, we can say, we have seen enough. As Vikram mentioned, I think this is where he was trying to allude to in the morning. Sort of grandfather certain applications. Now, then within this intended purpose, there is like compound-specific questions. For example, whether that pathway is going to cause any deviation of your prediction, right? So if you know your the 3A is already more than 70%, based on in vitro, and there's a mass balance data to qualify this assumption. And then they went ahead, did a isochronal study and come back and say, the initial setup of 70% more or less capture, what we can anticipate. And then they probably will go back and refine the model based on the isochronal study. But then from that point on, the question is whether that the remaining 30% is a concern or not. Because the label probably will focus on the 3A pathway. Now, if that alternative pathway is a concern, whether action can be, needs to be taken for that pathway, we will, in that case, probably will be partially granting the so-called waiver for 3A related, DDI with another modulator. But the alternative pathway, if we can be talked out of the case, the sponsor can or applicant can convince us that there's really no need to worry about that pathway, then it's a case by case, right? So you also keep the option of asking for post-marketing requirement if needed, yeah. But for the major application, if it's 3A and they have done the homework, following the workflow, it'll give us a lot of confidence. And this is, again, an area maybe we can discuss at the last session in terms of, at what point we can say the qualification is sufficient. Yep.
Thank you. Then our next speaker, that will be Leon Arons from the University of Manchester.
So Sue asked me to talk and describe sensitivity. Whether you think that's a good idea, you can tell me at the end. I certainly would like to thank Sue for getting me up at 5 o'clock this morning to come down here, however. So I don't want to be a complete pedant, but I'm going to start with some definitions. Actually, the phrase is learned societies. Learned is a verb. As I say, I won't be a pedant, though. So I'll start with some definitions. Firstly, of course, you get into the complexity of the English language. So it depends on which particular society you want to read or which particular group you want to go to. You get a number of different definitions here. So here we have one of validation, which tends to be used by the control engineering people. The process of determining the degree to which a model is an accurate representation of the real world from the perspective of the intended uses of the model. And Inya sent me that particular definition. One day I'll look up what AIAA stands for. And then we have qualification, which we've been talking about today, and this is the EMA definition. I won't read that out. Okay, so then we have sensitivity. So this definition comes from a person, an Italian called Saltelli. I'm sure that's the wrong pronunciation. But if you read the literature on sensitivity, this is the guru of sensitivity, particularly on global sensitivity. He's written a lot of the literature on this. And this is his definition of sensitivity: the study of how uncertainty in the output of a model, numerical or otherwise, can be apportioned to different sources of uncertainty in the model input. So quite important word there is uncertainty. And so I think it's important to make this distinction, which was made by a friend of ours from Manchester, Ivan Nesterov, the distinction between uncertainty and variability. So variability refers to variations due to inherent factors or natural causes of the system, if you like, the stochastic properties of the biology. Whereas uncertainty refers to variations caused by errors in assumptions and observations of the system, your inability to actually home in on a particular parameter, for example, which may be a function of design and data. Those two are quite different. They're not the same thing, and that's quite important. While I'm not being a pedant, let me actually just take the definition of identifiability, which I think you haven't got wrong, but you haven't defined it as closely as you should, and I've actually heard people amplify that during the meeting this morning. So what you've got to distinguish is about two sorts of identifiability. And the first one is called structural identifiability. And this is when, even with perfect data, you cannot estimate the parameters of the model. So here's a simple example, which is a straight line. So y equals a plus, well, if you like, intercept plus slope times x. But if you look at the way the slope is written, it's written as a ratio of b over c. Now, if you had data and you tried to estimate b and c independently, you can't do it. You can't do it even if you had perfect data. In other words, if you had no noise whatsoever in the data, you had the best design in the world. They are structurally non-identifiable. Of course, you can actually estimate the ratio B over C, but you can't estimate B and C independently. It's structurally non-identifiable. This is against, and this is what the use that you have in your document and what other people have been using it for this morning, deterministic identifiability. So this is a case where the model may be structurally identifiable, but the data is so poor, or the design may be so bad, that your ability to estimate the parameters is not so great. So the example here is the Michaelis-Menten model, and that model actually is structurally identifiable. However, as most of you know, it can be very difficult to estimate Vmax and Km independently. So, for example, if your data is at low concentration, particularly if it's below the Km, then you end up only being able to estimate the ratio. In theory, with perfect data, you could estimate the parameters, but given data, it may be difficult. Okay, it may sound, as I say, this may sound like semantics, but it's quite important to distinguish between those two. So finally getting on to some PBPK models, and I'll continue on identifiability if I can. So there has been some work on identifiability, and this is structural identifiability as I defined it. So Amy's in the audience, of course, is the first author here, and then James Yates, who apparently knows her, is also written on this particular topic. So people have looked at the structural identifiability of PBPK models. And certainly, sort of, you might want to call them classic models, which are perfusion rate limited in their distribution, turn out to be structurally identifiable. However, that doesn't guarantee that every PBPK model is going to be structurally identifiable. I'm sorry, Masood, you're going to have to do the analysis. Okay, so some people quite often put up a slide and say, this is an old slide. I can truly say this is an old slide. So we use this for teaching, or I should say try to teach our undergraduate students the difference between bias and precision. Okay, so you can see what it's all about. You can be very precise but not accurate. You can be, if you like, accurately wrong. There is a difference between bias and precision, and the point I'm trying to make is there's a difference between uncertainty and sensitivity. There's no point doing a sensitivity analysis if your model is biased. Okay, it may be the same as if you do it on an unbiased model, but you really have to get the bias or the accuracy sorted out before you can actually do it's been made dimensionless so that, in fact, it's been scaled, if you like, so you can compare these local sensitivities against each other. But because it's local, then it's only valid for a particular parameter value, and it's only valid, in this particular case, at a particular instant of time. For example, here it says at a time tm. So you've got to actually now choose what the metric is you're going to talk about, and which sensitivity you're talking about. So in this example, I've chosen to talk about the area under the curve. And so go and look at the local sensitivity of the area under the curve, and this is 0 to infinity as far as the differential equation would find it, at least, as a function of those two parameters, Vmax and Km. So this is what AUC versus dose looks like. Of course, it's nonlinear. And this is what the local sensitivity analysis looks like for Vmax and Km. And so what you see here is that at low doses, then the AUC is sensitive to both parameters, Vmax and Km. In fact, quite obviously it's sensitive to the ratio. So they're equally important. But as the dose increases, what you see is that the influence of Km, or not so much the influence, but the sensitivity to Km actually decreases, whereas the Vmax essentially holds up. And that makes sense, because at higher doses, you eventually approach the zero-order case. Okay? So the first thing to note about local sensitivity, or maybe the most important thing to note, is that it is actually local and depends on the value of the parameters at a particular point. So what's global sensitivity? So, as usual with these things, what you do is you go back in the literature, in this case the 1940s, and you find it. So this is the best way to make a name for yourself. Read the literature in 1940, change the symbols, and republish it under your own name. In this particular case, it's Kendall, who's actually quite a famous statistician. And this is an example from a biometrica paper in 1942. And the point of this is to show you one of the problems with local sensitivity, and we've heard this morning, is basically correlation between parameters. So this is a set of data. Now, I tried to look in the paper. I don't think it's real. I think he made it up. But anyway, he was looking at the relationship between mathematics ability and musical ability. So allegedly, people who are good at mathematics are also good at music. I definitely am an outlier in this particular case, because scientifically, my musical ability could be described as crap. Anyway, he also had the intelligence here, and they're ranked, okay? So I actually did the wrong thing. I did a Pearson correlation because it was easier than doing a rank correlation, a Spearman's rank correlation. But actually, the correlation coefficients are not that dissimilar to those in Kendall's paper, and it allowed me to do the graphics. But anyway, there's quite a high correlation between musical ability and maths ability. So about 0.721, and it comes up to the magic p less than 0.05, and enough said about that. In fact, if you plot it out, there's a reasonable correlation between mathematics ability and musical ability. All right, so what you can do, and this is what Kendall did, you can do what's called a partial correlation coefficient. He actually did partial rank, I did partial Pearson's. And basically, you look at the correlation between maths and music after controlling for the other variable, which is intelligence. And it's straightforward to do. You just regress maths ability on intelligence and music ability on intelligence, and you look at the correlation in the residuals. Lo and behold, basically, the correlation disappears. So in other words, it's intelligence which is driving both maths and music, apparently. With 10 subjects and made-up data, I won't actually go into the causality of that. But this shows you the problem with, and this is the problem with local sensitivity, one of the other problems with local sensitivity, that you have these correlations. So what's being done in terms of PBPK models? Again, thank you, Inya. You gave me this example by Brian Ingalls, which was presented at an ACOP meeting in 2015, and looked at this PBPK model, which is due to Bjorkman back in, 2001 or so. This was built for midazolam. and basically looked at identifiability analysis, structural identifiability analysis. Now, I used the wrong word, of course. It's a sensitivity analysis. But okay, all right. He's Swedish. So here we have the table of the parameters, and here we have the local sensitivities. Now, because it's local, he did something else. What he did was he calculated the local sensitivities across all the times in the study and then summed them up. So it's a pseudo-local cum global sensitivity. And what you see at the top up here is that the intrinsic clearance actually is the most sensitive parameter, and I guess there's no great surprise. And you see there the parameters are ranked. So there are some examples in the literature of doing sensitivity analysis. This is my friend Ivan Nesterov again. This is actually quite old as well, 1997. Looked at a series of a PBPK model for a series of barbiturates and essentially did a local sensitivity analysis here. More recently, there's quite a nice paper, 2009, by some people from Montreal, where they looked at a sensitivity analysis for a PBPK model, looking at the importance of the peak glycoprotein played a part here. And they did actually a global sensitivity analysis. They used, in fact, this rank correlation coefficient, which I was describing to you, rather than one of the more sophisticated methods, and I'll comment on that in a minute anyway. And what they come out with is a ranking of the parameters in terms of how the output is sensitive to them or not. And Fumic actually comes out to be the most sensitive parameter. Oh, okay, you can read into that what you want, but that's how it comes out. There are a number of these global methods. There are the partial methods I've been talking about, either the Spearman or the partial rank correlation coefficient. There are more sophisticated methods. The one that Sartelli actually sort of champions is a method called Sobol, which is after a Russian mathematician. And there are some fast Fourier transform methods. These latter two essentially are related to analysis of variance methods. In terms of recommendations, it's said that the two partial correlation coefficients work well for monotonic models. In other words, where the output increases in one or decreases in one direction as you change the parameter. Now that's true mostly of PBPK models. So probably these these partial correlation coefficients are probably adequate for PBPK models. The difference between the two is that the Spearman one is strictly only applicable to linear models, which the PBPK isn't. So perhaps there's an advantage of using the partial rank one. The other two, Sobol and eFast, have been looked at, and there are a couple of papers published on them. In all these methods, you can't do it analytically the way I did it for the Michaelis-Menten equation. You basically have to use a PBPK model and sample from it, which may require tens of thousands of samples. And therefore, you have to use some smart sampling techniques, such as Latin hypercube designs. But there are ways of doing this, and there's software out there. There's some written in R, for example, that you can use to do this. So you need something to sample, and then, of course, you have to run these algorithms. They're freely available, written in R, written in MATLAB. And so they are possible. But it seems that the rank correlation coefficients may well be adequate for our purposes. Okay, and I think that's it. Yeah.
Thank you. Quite nice view on this sensitive topic. Question, please. One. You did not touch their senses. No. Okay. Oh, yes, we have one.
If I just
Go ahead.
may ask about that midazolam example where they identified the intrinsic clearance, and as you said, of no surprise. But for these PBPK models, where often you have an uncertain, or you have a mechanism where you have validated with a clinical study and trying to do some simulations for untested scenarios, is this a required step to do? Such as was done in that publication?
Here's the personal view, right? And I can speak with absolute confidence from ignorance that there's the difference between the uncertainty sensitivity analysis and the validation is that the sensitivity analysis is a prelude to the validation. In other words, if you want to find out which parameters are important in terms of your model, then you carry it out, and if you can, of course, refine those parameters. Then you do your validation, right? Not the other way around. That probably didn't answer your question, did it?
That's okay. We can probably get to the
Okay.
discussion later.
Thank you. And then the last speaker for this session, Skottheim, Rusten. She's chair of the Modeling and Simulation Working Group.
Thank you. I'll just add some considerations on uncertainty analysis or uncertainty quantification, building a bit on the application side and what we would like to see. Just a disclaimer that the views are of my own. Uncertainty quantification. Why are we interested in that at all? And that's because we want to know how the various sources of uncertainty really feed into the uncertainty in the model predictions for the outcome of interest. That's what we're interested in. And these are just the definitions, and Lian already went through them. And I think I'm just thinking about it in this manner, with the aleatory uncertainty and the epistemic uncertainty, where the aleatory is the variability that's inherent to the system that you're studying. It's really the variability of the system, of your system, while the epistemic uncertainty is due to lack of knowledge somehow. It's not sort of true variability of the system or the physical, biological variability, but it's coming from some other sources of your measurement or your approximations, or just lack of knowledge that there is a process that should have been accounted for. So, with regard to the uncertainty and the approaches and the sensitivity, what is it that we want to do? Well, we want to explore the model properties. We want to understand the model properties, and we want to explore the appropriateness of the model, if there's a bias or if it's sort of the approximation that the model presents is that's sufficient for the purpose of use. And to do that, we would want to know something about how and the outcome of interest depend on a specific parameter or as a specific submodel of the full model. And we would also like to know something about how the outcome of interest vary according to the uncertainty in the parameters, in the assumptions, or other model aspects. And to say something about that, we need to do sensitivity analysis, and we also have to do uncertainty analysis to understand where the uncertainty comes from. And that can be done locally or globally, as Lian already had presented. And I think sort of as goes for the sensitivity analysis, which can be local or global or even strategic, which is what we mainly will be discuss or have been discussing perhaps, we can say the same about the uncertainty analysis. You can step into all levels to try to understand the uncertainty, or you could do it for specific parameters or aspects of the model. And what we have been discussing is when should we do it and why should we do it. And I think there are sort of very broadly three ways to step into it. You can do it based on suspicion, when you have a lack of fit and you really want to understand where you have to dig in to understand better or understand how you can use the model to predict. But you can also sort of be a bit more strategic and go into the analysis according to how you're going to use the model. What's the regulatory purpose of use and what's the impact if you are wrong? And you can sort of choose the areas of the model to dig into based on that. Or you could just do it as standard, that you're always going to do this. And I think we would like to see some aspects of it at least done as standard. Of course, sort of, we're not going to require that that's done for every model, then probably we're not going to see any models submitted at this stage. But we would like to sort of have some strategy and really sort of to go into this with the mind to understand the properties of the model and how uncertainty impacts our confidence in the outcomes that we're interested in. So uncertainty analysis, what is it? In my mind, I see this as a scenario analysis to identify the sources of uncertainty, an explicit systematic approach to understand the uncertainty. And as I said, I think the need has to depend on the purpose of use and the regulatory impact from our perspective, from the regulatory requirements to this. But sort of all areas are up for consideration. The parameters, the assumptions, the model structures, sort of the processes that we're trying to describe, and the associated sort of algorithms or whatever we choose to describe these processes. And also for the computational methods and the approximations that's introduced to solve the equations that we use. And the outcome of the uncertainty analysis is somehow to define the perceived boundaries of these aspects of the parameters, but also of alternative setups, if that is needed to understand a bit more how uncertainty impact the outcome that we're interested in. So just a few case examples, not so much to discuss the examples, but sort of ways of presenting them and what we normally see within the applications. We don't see much, if I can say that. The first example is an anti-cancer drug, CYP3A4 substrate with some very minimal 2D6 involvement. The model is a PBPK model. The purpose of use was information to place information within the SMPC on inhibition with medium, strong, and mild inhibitors. So that's sort of a high regulatory impact. It's going into the SPC. The qualification was done within the procedure. And I think it was sort of general agreement that in this ballgate we're okay. But there was some request from the regulator because looking at the fitting characteristics, it was clear that the Cmax was not described well. It was underpredicted. So there were some questions on the appropriateness of the absorption model of the PBPK model. So there was a request for local sensitivity analysis and to look into the sensitivity towards the absorption parameters and the FU gut. And the company came back doing these sensitivity analysis and then inserting different values of the FU gut and trying to see the impact of that. And the one in bold is sort of corresponding to the one that was used in the original model. And also exploring the impact sort of in the first graph, it's really sort of exploring what was observed, I think. And then in the second graph, it's trying to see what would the impact be on the scenario that's predicted, the one that sort of what's the purpose of use of the model. And this, again, was sort of trying to see the impact of the FU gut on the outcome of interest, which was Cmax and the AUC ratio. And in this last table, this was summarized, sort of looking at the observed data, which was observed, the ratio for AUC and Cmax, and then the original model, how that performed with the input as submitted in the first submission, and then the two additional scenarios that were simulated, trying to see how much that would impact the ratios and sort of could we broadly trust the predictions. And you can see you're still not quite there with regard to the Cmax ratio. It's still underpredicted. But I mean, it's in the ball gate and it's not really affecting the decision as such whether or not to accept this. So this was accepted. And I think you could sort of surely do more and you could dig more into it and that could have been interesting. But in this instance, this was considered sufficient. The next example is still an anti-cancer drug, CYP3A4 substrate, PBPK model. And the purpose of use was to inform the assessment of drug interactions of a more complex interaction with time-dependent inhibition and mixed inhibition and induction. The regulatory impact was perceived as low to moderate. This was really not to use into the SMPC or to extrapolate. But it was submitted to support. The qualification was presented within the procedure, but just to say that this was not considered qualified for that purpose, but still sort of a value to have it in to understand. And there was some sensitivity analysis submitted, and this was on AUC, which was presented at the outcome of interest. And with regards to the uncertainty analysis, there were sort of not rational as such for how it was done, but it went back to the in vitro experience and some other considerations on the parameters that was investigated. And there was some local sensitivity analysis looking at the absorption parameters and the TDI parameters. And again, it's not sort of to go into the data, but I mean, this is local sensitivity analysis and exploring the impact of varying the FU gut on the fraction FG of the substrate. And I think it helps to submit this kind of sensitivity analysis because it helps the regulator to understand the properties of the model, and it helps us to have sort of an explicit discussion around the confidence in the models. And of course, with the high impact procedures, this is more important than the other ones, but this helps us to understand a bit more what we can expect and what we can, the level of confidence we can put into it. And of course, sort of the next level of the sensitivity analysis were to check how that impacts the AUC ratio, which was of interest. And this is sort of, you can see that there is a slight sensitivity, but again, I'm not sort of interested in the interaction as such, but I think this is what we would like to see. And maybe this is probably not even state of the art, that there could be much better way of doing it. But still, every attempt to do this better helps us in our evaluation. And this sort of brings me to the third example, which is more about the wish list. It's an hypothetical case example for a pediatric application. PBPK model informed the dose selection, which would be moderate to high. Normally moderate if it's to inform, but it could be considered a high if sort of the risk associated, the consequence if the predictions are wrong, are big on the clinical side. Then we have to proceed with caution, and we need to know the confidence in the prediction to do that evaluation. So we would like to see the qualification within the procedure at the current stage. I think we wouldn't expect that to come in. And we would like to see some uncertainty quantification for the outcome of interest. And of course, these should be defined and discussed within the exposure-response relationship. And probably it should be Cmax, it should be Cmin, AUC, whatever is of interest. But most of the times we are really interested in the full curve as well to understand it. So this has to be discussed within the procedure and the submission. And we would like to sort of see some uncertainty analysis, strategic and explicit discussion of what is the uncertainty. And we would like to sort of have that turned into sensitivity analysis as well. Sort of both what's sort of the major factors impacting the outcome, but also sort of how does the outcome vary regarding to the what-if scenarios of the analysis of the uncertainty if we really are interested in that. So the wish list for the uncertainty analysis as such would be to always look at the sensitive parameters, to look at the fraction metabolized in this setting, to look at the maturation function. I mean, the scientific knowledge on those are not state of the art. We're still lacking knowledge, so we would like to sort of explore that. If it's really is impacting the decision that we want to make with regard to the dosing. And we would also like to have some consideration around the virtual patient population parameters. Very often these are sort of healthy children, and we would like to understand how that translates into the patient that we're actually going to study and to dose. And of course, other relevant assumptions for that modeling exercise. And there could be other aspects as well, but this is what we want you to present to us and have an open, explicit discussion around, because it puts us in much better understanding of what we can, what we should understand and what we should sort of dig further into to allow these predictions to taken forward to their best. So thank you.
Yes, thank you, Ine. I'm certain now that we're behind time schedule, but I'm uncertain what the final impact will that be for today. So, a question, please. Yes, Ping.
Yeah, very nice, Ine. So for example 1 and example 2, when the applicants did a sensitive analysis, either based on your request or they voluntarily did that, how much do you weigh with regard to the sensitivity and the outcome of the PK of the drug itself? For example, ibrutinib, if they only show you that, or like if I were the sponsor, I respond back by saying, it might have impact on the DDI prediction. However, if I change that view, too much, my PK prediction totally crash. There I can already assure that this current value is a good value to begin with. And then the second case for drug X, we also encounter this kind of submission. People try to argue, okay, we don't want to do the mid-algorithm study because the simulation is like this. So when you have a combined self-induction and self-inhibition, how much do you weigh in terms of the multiple dose PK of the drug itself? Because if there's a self-inhibition, there may be nonlinearity that can already help you to exclude the possibility certain combination of parameter. Doesn't mean they're identifiable, but at least they may be cancelled out because there's no nonlinear pharmacokinetics at all after multiple dose, or like when you dose escalate. So these are kind of combined.
Yeah, no, I think it's probably Anna and Eva is better to answer it, but I would just say that you have to look at the total picture, and we all would always do that and sort of to try to wiggle it along, but then sometimes it helps to dig down a bit to understand some parts of it, and then you have to weigh it in. But Anna?
Yes, if we should go for, I don't know if we should talk about ibrutinib as such, but I think at that time we were, the applicant could convince us that changing the sensitive parameters, the PK will be way off, and there were also some other simulation showing us that these sensitive parameters was quite okay in the model. I think, if I recall it correct, maybe. And the other question was?
Compound X for drug as a inhibitor / inducer.
Yeah, the dose, multiple dosing. Of course, we look at multiple dosing. I think that's quite important for PBPK also, that not only have single dose. And we think about that also, and look at how the data looks at accumulation and induction inhibition after multiple doses, also in the totality of data, as Ines said.
More questions? Yeah, go ahead.
Yes, François Bouzom from UCB. I'm not sure to have really understood the differences between uncertainty analysis and sensitivity analysis. So far, I was thinking that sensitivity analysis was used to see the impact of the uncertainty on some parameters. So I'm a little puzzled. So if you can just help me, I hope I'm not the only one. But
No, but please help me. I think this is my understanding of it, and it seems to be a lot of definitions going around. For me, sort of the uncertainty analysis, and I'm happy to be corrected or use other terms, but it's about understanding that domain, that parameter, what's actually the boundaries of it, to use that to pull into the quantification of the impact. So the sensitivity, I think Leon is probably much better to answer it anyway, but that's sort of about how much do your output depend on the input. Whereas for me, the other aspect of it would be to understand what's actually the perceived boundaries of that input. You have measured it, but is that really a true measure of what it should be, or should it be broader? So you need both aspects. But I'm happy to be corrected on the terms.
Leon, comment, please.
Not at all. François, you're exactly right. That's exactly what it is. So they are different, and one drives the other. So you're exactly right.
More questions, not only about the last presentation, but in general on this session. Go ahead.
So Nassim Shebley from Sanofi. I just take the opportunity of the last question of François to mention something which is, I think, is important for me, because it's the distinction between the uncertainty on the parameter and the variability in general. It could be inter-individual variability or intra-individual variability, but when we have model parameters, there is a corresponding variability for this parameter, and this variability becomes a parameter itself. And we can then talk about uncertainty around the parameters, but also the variability of these parameters. I mean, even the variability, we can have an uncertainty around the estimation of the variability. And finally, just to come back to the PBPK, and maybe there is no choice, and we mix a little bit the variability and the uncertainty, because when we perform our sensitivity analysis, we are using different input values of the parameters and see which is the outcome to cover the between subject variability at the end. So it's general comment, but I think it's
So the distinction between uncertainty and variability, I think the best sort of analog I can give you is the difference between standard deviation and standard error. I'm saying this with statisticians in the room, so I'm shooting myself in the foot here anyway. So if you measured the height of a big population of people, there will be a certain amount of variability in that value. If you increase the number of people in your population, the standard error of the mean just gets smaller and smaller, but the variability never goes away, right? It's the variability in the population. So they are different. They're not just mathematically different. They actually have completely different meanings.
Questions on it? Quite, yeah.
Question on a different topic, if that's okay. That's to innate for the hypothetical example 3, that you have the compounds X and substrate Y, that is intended for those projections in pediatric studies. So won't the qualifications plan should be already included in parts of the pediatric investigation plan already, rather than it will be requested as ad hoc to the sponsor when during the submissions of the results of the analysis?
I think normally it will be sort of presented the plan for how it should proceed when you agree the PIP. So either you would have it already or it would come at a later stage, and it depends on the procedure, how and the impact of use, so how and when or if it's going to be presented. That's your question.
Yeah, so it's more about the level of information, how much of the sensitivity analysis plan that it has to be included in the pediatric investigation plan for you to understand the intended, how we're going to look at our data, and then judging how the parameter, whether how big is the uncertainty is, how much is not quite. It would be nice to have like more information around that. And also in the MIT3 paper that we have because in the whole morning and afternoon we talk about assumption as a very general sense, but we have classified the assumption into physiological assumption, disease assumption, mathematical assumption. So it would be good to understand like the level of information that you would want for this analysis.
Yeah, I think that is well taken, and it's also because this is in a state of discussion, sort of how to lay it out and what to require for the PBPK model. This is why you're here, sort of to give us input and opinions on what we should do and how it should be done to make it feasible. But I agree, this is important sort of layout or guidance for how to present it.
Thank you.
I also want to respond a little bit, because I think at the moment the assumption discussions in the reporting are not very well done. So that's actually why we are lifting assumptions. It could be on system parameters, it could be on the drug model. So I think that's one reason why we think assumption is very important. So you need to do that when you submit a report. If it's for PIP or for a whatever market authorization application, you should discuss your assumptions in your modeling exercise. That's very important.
Yes, this is Erik Hagren, Uppsala University. That was connected to you there, Anna. If this sensitivity analysis has some place in the qualification as well in the process, or if that is like two separate things.
I think it's. Would you want to?
No, it was actually a question that I was wanting to ask in the morning, but I don't think that we know that right now. But it seems to me at least reasonable that it could be used already in the qualification part. So it would be a qualification with a certain sensitivity analysis on certain parameters. But this is something that we have to discuss more to know.
Yeah, and I think it's an important discussion. I think it could help quite a lot to do that during the qualification, and then you have the outline of where sort of your expectations for uncertainty from the system model, because the impact of it could vary depending on your outcome of interest. So, and that could change a bit for the specific application where you plug in your drug model as well, but it would be sort of make that discussion easier if you have sort of done the groundwork better for the qualification on the system side of it. So I think it's going to help us a lot to start doing that systematically.
Does anyone have an opinion if we should include sensitivity analysis already in the qualification?
If I can just remind the comments from Leon just before, he mentioned that sensitivity analysis have to be done before qualification. Because so at least my understanding is, and I fully agree with Leon, you use the sensitivity analysis to define the parameters which are sensitive or uncertain or whatever, and then you focus your, let's say, your whatever you can do, and we can discuss about that later on these parameters, and then you can forget the other. That's my opinion.
I think that I was thinking more from a variability perspective, like a sensitivity analysis to account for variability in KI or variability in some parameter that we have determined, but we know that there is some variability attached to it. So not actually the way Leon is, but I agree, it's a very good approach to also make this in order to identify parameters which may also limit the qualification in a way, or we have to think about to have a particularly big range, for example. So it's in the data set. So I think it's two separate things.
Yeah, Venkatesh from AstraZeneca. It's a clarifying question. Since this session is reporting as well, in the draft guideline, you mentioned that you should, if possible, you should include the mass balance of the drug, in the sense the metabolic pathway, understanding of metabolic pathway in a format, a schematic format. But for example, the pediatric investigation plan comes in around phase 2 stage. We may not have full understanding of metabolic pathway. So is it a suggestion or is it a requirement for the PBPK report based on the guidelines you're proposing?
I think for the PIP, you usually don't have so much report in the PIP for okay. PBPK modeling, so then you don't need this mass balance diagram. Okay. But of course you need a description of your elimination pathway. It's usually described in the PIP at some level.
But in oncology setting, for example, some of the submissions will go based on phase 2 data. We may not have drug-drug interaction studies, maybe ongoing. If that is the case, what do you propose in the sense?
Yeah, but you still don't have your qualification either. Okay. For the intended use. So it's quite early. Okay. We probably don't need it for a PIP, but we will come back to the details. It's a draft guideline. So.
Okay. Thank you.
And just comment on that. There's a difference between the mass balance of the PBPK model and mass balance of the actual drug pharmacokinetics. You're talking about the mass balance of the PBPK model. Even if you've got the metabolic pathways wrong, you can still have mass balance in the model.
We are describing a mass kind of elimination or quantitative mass balance diagram that we would like the applicant to report in the PBPK report. So it's actually the ADMA mass balance we are talking about. Right, yeah.
It is Amin Rostami, University of Manchester, and also Sertara. I think on the sensitivity analysis, I am not sure we are actually making the distinction that we should make with regard to the system parameters and drug parameters, and then within the system parameters for which we independently have got adequate data that we know what exactly they are, as opposed to ones that we may not know what exactly they are. If something is actually certain, and we have number of different ways, different studies, for instance, we know the size of liver and it's linked to the size of the body. Doing a sensitivity analysis on the liver size and its impact on the overall clearance and AUC, etc., it's actually a waste of time. While if we are looking at for a parameter, system parameter, for which we haven't got that level of confidence, then you can actually get something out of sensitivity analysis. However, if you've done that number of times and adequately, going back to what Ping was saying, and shown that with certain value, you are actually recovering series of different independent sets, you have to do that just once and then settle on it and then move on, not every time to repeat the same analysis. You have to do it for validation, but you don't have to do every time for every single drug. This is very different when you are starting to look at sensitivity for the drug parameter, because for that, definitely what you are going to see and what you are going to extrapolate is going to be dependent on the parameter you are putting in. And unless you have got independent sets that they are defining that value, therefore you are going to actually need that sensitivity analysis. I think that is the distinction that we probably, the apparent, I would say, disparity that we saw between what Leon was saying and what actually Masood was saying earlier on. So I think if we make that distinction, actually there is no difference in those two.
Yeah, and I think this is what we would like to see better reflected within the submissions as well, either if it's for qualification or for the specific application, because there are a lot of processes and parameters that are well qualified and we know, but this is not so well reflected within the submissions that we see, so we do not know that. And of course you can sort of start doing this for the sub-models, and the sub-models of the liver or whatever they may be fully qualified, and you know that, and then you can plug it in and sort of see where you strategically have to do your other analysis and understand the impact of uncertainty. But again, this is not, we do not see this, and we would like to see that. So I think that's the main point.
I fully agree, but what I'm trying to say that we should have a list of them that we have settled on, as a learned society or whatever that we want, sort of to come. And there are sets that they are still subject to debate. For instance, the fluid and their volumes in our GI tract is still subject of debate. Not everybody has settled on them. Therefore, you can't go and stick a number and just say that, okay, this is basically looking good. Because, we have got independent observations that they are coming up with different values. But it is not the same when it comes to, as I said, for instance, size of liver. We have to settle on some of these, and then for some others, say, because we haven't settled, because there is not certainty in these parameters, all the time we would like to see sensitivity analysis even from the system point of view. That's exactly, what I try to actually convey.
I'd just like to ask, how many parameters do you think there are that are settled on then? Within maybe the three main software providers. I know how difficult it can be to settle on a value, even when you think it is quite well defined. If you could provide us a list of these parameters, it would be really useful. And, if everybody had agreed those parameters, I agree, then we wouldn't have to explore them in the way of a sensitivity analysis.
That's a very good point, Sue. I would say that whatever we have published, because we were not ourselves were certain, but obviously we put it into peer review. Even that is not the ultimate thing. But whatever that we have published as a peer review and summarized, we believe that they are withstanding, any scrutiny, etc. Whatever that we haven't published yet, maybe we are not sure ourselves. But as Masood said, that whenever we are settling on those from the R&D team within SimSip, we are trying to put them out. And whoever wants to challenge them, they can challenge and come with something else.
But of course, we as a regulator also would like to have a worst case scenario in some cases, because, for instance, the KDEG value that I know that have been published from you, of course, we don't think it's settled. So we would like to have a worst case scenario from the applicants when they are using a KDEG value, for instance. So of course, it's your opinion that you think there are parameters that are settled. We also need to harmonize among the industry and regulators that we think they are settled. And at the moment, why we are pushing sensitivity analysis is actually that we don't see it very often. And we have to ask for it all the time. And it would be good to have that from the beginning, that we don't waste time from us and from the applicant asking for that all the time. So that's why we are pushing on sensitivity analysis. And we also would like to address uncertainty in the end. So we actually know the prediction, how certain are the predictions. So it's very important for us to have sensitivity analysis.
Yeah, thank you. I wonder if that's, again, coming back to the guidance, wouldn't that also be dependent on the specific context of use and level of impact as one side of things? And then the other aspect is, if we're focusing on the pathway for a submission of a specific PBPK model as part of the novel methodology qualification, wouldn't that also be part of an opportunity to have those types of informed discussions as part of the scientific advice stage in light of the specific context of use and the proposed impact?
Yeah, that could be one way, of course, of handling that. But of course, we have not discussed it internally, so we have to see where we end up in the final guideline.
I want first to invite the panel members to the front who are not sitting here yet. Ping. Andrew, sitting already, yes. Kevin is here. Hey, Martin. Oh, we're almost here, all of you. Sitting on the first row. There's still enough place. It's over here. Can sit here also. One left. So, go on with your questions. Also specific to the panel members now. I hope it will trigger further discussion. Roland, go ahead.
Maybe it's been said, but I just want to make sure we've got clarification on this sensitivity analysis issue. I mean, one of them is the underlying physiological information in which there is variability and there is uncertainty, and they vary from one component of the system to the other. And that is nothing to do with the drug unless the drug disturbs some of those systems. And then we've got the sensitivity of the parameters for our drug to those underlying variability or uncertainty of the underlying physiological values. So let me give you an example. We're talking about a drug which has low clearance drug. So we say, well, blood flow is not going to influence their clearances because we know something about that. Whereas another drug, it's a high clearance drug, and we know that flow is going to be very important. So the issue is the work that you do on the underlying physiological model is independent of the one you're going to apply it to. And I think that what we could do is start building up a body of knowledge about the confidence we have or don't have in the underlying physiological system as a separate matter. But then when somebody applies it to their drug, they have to show that with those underlying knowledge, what is going to be expression in terms of the sensitivity for their drug of the input side to the output side. And maybe that is what everybody's clear about, but I wasn't quite sure. That's why I thought I'd state it.
Ina?
I think this is what we would like to see, is the point of it. And then sort of in addition, sometimes you also change the system parameters for some subpopulation, and of course then you have to have some considerations around that as well. But I agree.
Then I think we have to acknowledge that the system is evolving, the knowledge is evolving. Therefore, my concern would be ossification. We'll think we've got the model, underlying physiological model, but there's a lot of it that's still uncertain about it. And particularly as we moved beyond just healthy volunteers and you start moving out into the patient population issue, which ultimately I think is where we need to be.
Yeah, Leo, go ahead.
So as usual, you're right, Malcolm. The issue with what you're saying, of course, is the confounding with the uncertainty problem with the parameters. So the model we have, in all its beauty of 14 compartments, etc., is really a pretty gross approximation to the body. And then what people then do is they start sort of fine-tuning various parameters such as the KPs, etc., to actually explain the data better. Whereas part of the cause of that, of course, is in fact the underlying model misspecification of the physiological model and the parameters you're speaking about. So it is evolving, and you're right to actually point out that distinction.
I agree, and I think it's an important point, and sort of these models are approximations, and they are very coarse approximation, and we really need to increase the resolution because there are a lot of aspects of variability that we don't understand. So, I mean, should not be set in stone, but this is what we have, and we should use it to its best and try to explore it. So.
Yeah, I think my point was that we don't start modifying the underlying physiological model. Leave that as it is, and then deal with the drug. I think there's a tendency sometimes to make approximations very early on because you're already thinking about the drug, and that wouldn't help us because it wouldn't build up the basic knowledge. And as I said, as we move to different disease groups and different ethnic groups and everything like that, we'll need to build up the underlying physiological body of knowledge. And that's the one that I think we need to conserve and enlarge upon.
More questions are from the panel members. Yes, go ahead.
Yeah, Liming Zhang from Takeda. The question for Pin, first, thank you for your nice presentation. You did assessment about predictive performance. So my question is, what kind of platform you use, or based on you assessment based on different platform, or your own platform, or specific platform?
Most of the studies we have all these major platforms, data from all major platforms. I couldn't comment on like which one more heavier. I mean which one is heavier than the other. But these are all platform based.
Thank you.
I have a general comment and also a question. So the general comment is, can we leverage the experience that FDA had, that Ping presented today, in terms of the acceptance criteria, the review process, and expectations to make this process a little bit smoother? Because it seems like there are a lot of publications from FDA on this topic, and with the presentation today, I see some potential synergy there to make the PBPK guidance a little bit more harmonized, if you will. So that's just a general comment suggestion. But going back to the acceptance criteria, we talked a little bit earlier about twofold, 1.25, and Ping showed several criteria there. My proposal would be to keep that unspecified and have everything in the context of the exposure-response understanding, relationship understanding, as well as the therapeutic index of the drug, where the sponsor can predefine that criteria. And then, of course, it's up for discussion. But I would be proposing that not to specify that criteria.
First of all, I can mention that there is contact, of course, for this guideline also with the FDA. We try to harmonize as much as possible on certain issue if there is the possibility, of course. And that's not only for this guideline, it was also on the bioanalytical guideline. Now we're trying to do it for the bioequivalence guideline if we need an update. So there's close contact to see if there could be an harmonization. Go ahead.
This is a question to the EMA. So in the very initial presentation, we have seen an increasing number of applications of PBPK modeling and simulation to support the sponsor's application. And I just wonder, did you see some kind of good practice example or something that could serve as a role model? Because you commented on you want to see sensitivity analysis because you probably didn't see it all the time, but sometimes. So is there is there something, one could start off rather than discussing everything from scratch? I was just wondering.
I think I could just answer from my own experience. I don't think there's anything that immediately comes to mind as that we've seen straight off, but I think there are procedures that we've gone through and that we've asked a couple of round of questions, the model's been refined, and at the end of those processes we probably have got what we require. So there are examples there. Whether we can share them publicly or not, I don't know. We'd have to look into that. But maybe it's something we can think about putting into a publication or something like that.
And of course, there are some ways of presenting. Also, we have a picture in the guideline how the model has been updated, the drug model. That comes from one application, for instance. So we use the things that we see also that we think are good. So yeah, of course we will add things in the guideline, but of course we can't present, I think, details from applications like that. It's more on a general level.
Yeah, I think that a little bit more detail might be present in the DDI guidance, where you have identified that it's said which parameters they want to have the sensitivity analysis on and so on. So you might have a little bit more details there compared to in the PBPK guidance, but no examples, of course.
I'd like, if I may, to just go back to the comment that Malcolm made. That, and this is more than a comment, a question for the entire panel. Is so what are the appropriate ways of addressing the issue of the underlying physiological model? What part is settled, and we can all agree that it's more or less settled? What parts are dynamic and are changing, and what are the issues there? Because I think if we create the appropriate forum for addressing those issues, then we'll have a systematic way in which we are all contributing to advance the knowledge, rather than, publishing, sort of a cottage type of scenario where you're dropping here and there, and then the answer is, well, it's there. So you should feel confident because it's somewhere. And I think having a more systematic way of addressing that will really help advance this issue.
From the panel, comments on this one?
No, I agreed.
Oh, you agreed. The regulator agreed. Go ahead.
I'll stick my neck out on this one, but really one concept, the free drug concentrations. I've seen PBPK models that still consider total concentrations, meaning bound and unbound, while the applications we're talking about here, pharmacologically speaking, they need to be unbound concentrations. And that shouldn't be something that people still debate or make an assumption and use a model that is not considering free or unbound drug concentrations. I don't know if that's in particular what you're looking for, but...
Of course, go ahead.
No, that wasn't his question. He's after the basis of the physiological model. I mean, I was waiting for Malcolm to jump in. Yeah. Okay, so let me give you some fodder to tear me apart. So my understanding is a lot of the data, the physiology data, the blood flows, blood flows in particular, are quite dated because they were done at a time when maybe ethics were not as a little different to they are now. Organ size is a bit better and so forth, but some of the physiological data may need updating. I may be wrong about this because, and the reason I say that is now with modern imaging, then probably there could be much better data out there. But I know that particularly for the animal studies we use, the data we're using is really old in terms of the physiology. So there are two parts. I mean, obviously the physiological parameters, but then of course there is the structure of the model, and I'll let Malcolm comment on that one.
No, Leon, I think the comment you made was also this morning. I had similar long similar line. So I thought you were thinking I'd jump in about protein binding. That one is. I don't think anyone who seriously thinks about the subject would disagree that we should be thinking about unbound drug. I think the complexity that comes about is the unbound concentration where. And I think that is often the one that causes us much more problems than the concept that the unbound is what we should be interested in. But I think we're not talking, but that's a drug-specific issue rather than a physiological issue, although they obviously merge in some places. But
back to where I agreed, which was on the system model and the qualification, because I think and what I agree with is that we need to work together to fill the gaps and to understand where they are filled already, where we have the confidence. And I think we really need to get together to get the data sets there to understand which scenarios or which purposes of use that we can qualify, that we can use. I mean, it should be used anyway to inform, but where can we actually also use it a bit further? And we need to gather the data together to see where we have that confidence. And in a lot of the areas, we do not have that confidence as of yet. And that's some of it is due to that the system model and the processes that we are describing are not sufficiently precise. So we do not have the precision to make those. So of course, in that area, the model has to be improved. And in order to fill that gaps, we need to work together to fill them, because it's a huge job. And that's not what we're discussing here today. That's on the next level. But of course, if we systematically try to see where we have the confidence and qualify, it's going to be quite clear where the gaps are as well. And then we can improve. So I think that's way ahead, but it's an important aspect of it.
I have the impression, so it's McLuby Novartis again, I have the impression Malcolm has kind of hit on the vein here. I think we're getting to something that we can think about actually qualifying when we talk about a physiological system and that we put drugs into. I mean, to exemplify this further, remember at the extrapolation workshop, a clinician asked one of these wonderful naive questions: do we have a PBPK model for biologics? And there was silence in the room, and there was some attempts at answers, but the answer is yes and probably more no. For a lot of biologics, we don't, because the actual system data that underlies it, as Leon pointed out, we don't even have some of good information on things like lymph flow and other things that impact biologics. So all the discussion so far today has been on small molecules, which is okay, but that's about maybe, about nearly half our therapeutics these days are biologics, and it's not going to get less, I would say. And there we've made no progress at all, and there's been no presentation on biologics so far. And what are the systems stuff that we need to figure out and qualify in terms of biologics? So I think we're probably still a long way away. But I think from Malcolm's point, though, I think what we are trying to qualify is what are the general things that we've learned that we can apply to any drug, ideally, well, we'll even say small molecules, and can we agree on that? What's the minimum amount we can agree upon? And when you put a drug into this and it looks different from what you expect, well, then you ask the question, why? Is it because we've got something wrong in our basic physiological set of assumptions, or is this something specific to do with the drug? But I think we have to get away from the drug and physiology model all muddled up together if we want to actually qualify something.
Just one comment for Michael's sake. There are physiologically based models for biologics already available. I think both in Gastroplas, PKCM, and we have publication. But you are right, the physiological data are more limited for biologics. So the models are out there, and the publication out there, and the sources of parameter where they are coming, again, they have been published.
But sorry to come back on that. I mean, the good models, and I say Wilhelm, I'd like to hear your comment on this, is I've seen some of the work that Wilhelm has done, and they're based upon making some broad assumptions rather than specific
physiological parameters very often for like things like blood flows and stuff like that, which we can use for small molecules. I don't think the models really invoke a lot of those principles. Now, I don't know, I'd be curious to hear Wilhelm's comment.
Yeah, thanks. I think there is a very nice review or article by Hannah Jones about using PBPK models for dose selection, and she has, I think it was the first article I saw where an author had both small molecule drugs and then large molecules, and she described, or the authors described, the state of the art, but also where there is still lack of knowledge. And for example, she was kind of worried about the fact that different groups use not only different physiologies, but also different parameter values, and just specified for the lymphatic flow, there were like 3 orders of magnitude differences for one and the same kind of physiological process. Yeah, and I think it actually boils down to the question how physiological we should be in a PBPK model. So at the end, you cannot identify lymph flow, you cannot identify the reflection coefficients. What you can is the product of the lymph flow times 1 minus the reflection coefficient, which is basically the inflow into the tissue. So should we then explicitly have lymph flow and the reflection coefficients in a PBPK model, or should we just say, okay, we cannot identify both of them, so it's probably risky to have it as 2 separate parameters, so we just lump them as one. What we did in our model, we nevertheless stick to the 2 parameters, because I think if you fix one of them, the other one is kind of identifiable. And now if you are interested not only in monoclonal antibodies, but maybe in fragments, then I think it's a reasonable idea to continue with the same lymph flows and then maybe change the reflection coefficient, because this will then allow you to analyze size effects. Yeah. And we didn't have a very detailed distribution model. We just used the antibody biodistribution coefficients, which have been kind of validated against quite a lot of data independently, as people did for, and Malcolm is one of them, as was done for small molecule drugs. So I think I'm not a fan of reducing everything to just the simplest possible dimension. You should see the physiology, but I see a risk if you offer this physiology that users will just change it without knowing that actually these parameters are not really kind of independent. And I think I haven't really, I don't have a solution to this. But because if you lump everything, the next biologist you asked will ask you, like, where's the lymph flow? I know it's related to lymph flow. Where's the reflection? Yeah, I know there is a permeability, extravasation limited tissue distribution, so somehow size should enter. So there is kind of this, you have to weigh the both aspects. Yeah.
More questions or remarks? You're all certain about your uncertainties?
I think there's still some variability on that.
Yes. Sue?
I just wondered where we've got to in terms of global sensitivity analysis. Sorry? Oh, okay. Just wondered where we got to in terms of the global sensitivity analysis question. Is there a general acceptance that we do feel that that would be something useful to do?
Some answer on that question. Who has an idea? Leon.
So, Sue, can you sort of redefine your question a little bit? Are you saying global versus local? Should we do it at all?
I suppose global versus, so in terms of there are usually quite a number of parameters that we might want to investigate both drug and system parameters. Masood sort of made a case for not doing it. He thought we shouldn't do it, but then other people have said that we should do it. I just wondered if we can get some sort of consensus on it.
Well, I guess the simplest thing to do is the local sensitivity analysis. There's no question about that. And in certain situations, it may suffice. Apart from the obvious problem with the correlation of the parameters, the other issue is, where do you do it? At which parameter values, at which time points? So there's an issue there. And global addresses that, not just the correlation, but as the name suggests, it looks across the whole range. My reading of it was that in terms of computer effort and in terms of people's ability to do the analysis, the rank correlation methods actually work reasonably well and are moderately easy to do.
Just going back to the point, based on the experience that we have seen, I think people, when they are developing a drug, we are talking about the specific drugs, they have a good sense of, or they should have good sense by the time they start to come to a submission. So the weakest point in the parameter that they have identified by that point. So I think the very good example was the three cases that you mentioned in it. If you got, it's very obvious. If you have got the gut metabolism, this is the parameter that you have to look. There is no question. You don't need to do any global sensitivity analysis or local. That's the parameter you have to look into it. And it is the same for some other parameters. That the reason what I'm saying that the global sensitivity analysis is sometimes you don't have any clue. And I think Leon mentioned some of the limitation on the even current one that we say that they are generalized one, the global one. The linearity that they are there, the assumption. So in most of our model, we don't have linearity. They are nonlinear. And sometimes they are highly nonlinear. If you go to any DDI, you are nonlinear. If you go for TDI or induction, they are nonlinear. If you have a bit of absorption, it can be nonlinear. You go to dose escalation, it can be nonlinear. I don't want to make a bigger statement on the correlation one. Again, you are making assumption on those. But if we incorporate our own knowledge, we can better. This is my personal view, not the SIMSTI view. You will be able to better identify the parameters that are important, and you do sensitivity analysis. Sensitivity analysis, we are big fan of it, but specified and inform. So inform decision making on what parameters they should be done on sensitivity analysis. It is the better approach rather than going across the board and doing global sensitivity analysis.
Erik Hagren here speaking. I am wondering about EMA's how they would consider like multi-dimensional sensitivity analysis, like if you're changing multiple parameters in the same time to synergist or to viewpoint on that, because often I suspect that people do one parameters at a time, but I mean if there's a complex system, non-linear system, so on, I mean the changing or the sensitivity to changes in several parameters may be completely different, I suppose. And this sort of analysis could be huge, obviously, if there's many parameters that are sensible, so to speak. Do you have any reflection upon that, or how much sensitivity you can cope with, so to speak?
I think that is on my wish list. I think we have to increase the standards a bit about how we build our models and how we explore the properties of the models to truly understand and go forward. But sort of in this setting, that's not the starting point. The starting point is that it has to be sort of related to the impact, the regulatory impact, but we sort of want to see as much as we can, as we need to take our decision to understand it. And I think it's I'm happy to have Eva or Sue or Anna to comment in on that, but I think we need to we need to see more than we do at this stage, because it's not done much in most of the applications. But as for the methodology and sort of the advancement in the field, I think that has to come from other sides, from your side, from the academia, and from the vendors.
I mean, I think maybe it might depend perhaps on whether or not there is any sensitivity. So, I mean, if you're looking at two parameters and you change them and the outputs don't actually change depending on those inputs, then putting them in the model together would perhaps be a not particularly fruitful thing to do. But if you put them in individually and you see something happening to your outputs, then that might raise in your mind, well, maybe I should put them in together at the same time. So maybe a kind of data-driven approach to the analysis might be a more appropriate thing to do, rather than trying every single possible combination of all the parameters you can possibly look at. I think also, if you do have highly correlated parameters in your models, then it would make sense to vary them at the same time as well, because it seems unlikely that one would change and one wouldn't. That's what correlation is.
Maybe last comment before we get to the coffee break. Can you hear me? Okay. So I sort of agree with Masood with regard to when you do the sensitivity analysis and for what purpose, right? So normally what we observe is sponsors submit the application and using a software, and there's an intended purpose, be it pediatric PK prediction or DDI prediction, and then they usually just do within this question, do the sensitivity analysis around this question. And my sort of a personal opinion on global versus local has been that maybe I'll change my opinion down the road. But so far, based on the observation, I thought the sensitivity analysis is more like a methodology. It's like a way for people to say, okay, whether I can entertain the question around variability. Let's say in vitro, I'm really not sure this Ki is within this tenfold. Let's do that. So sensitivity analysis is a method. It's not a real kind of a model sensitive analysis as we have discussed so far. So we have to differentiate these two. And so far, it's been mainly on testing anything that is uncertain. So it could be just a couple of parameters or just one parameter, but it has to be within the context of use. Say if you're predicting food effect, and I think it's more important for the community to define, what if I have a model that has been middle out tested for fasted PK data. This verification process already helped me to confine a lot of space for multiple parameters. Then the goal is to predict the effect of food on my drug. What are the essential parameters? And those parameters, whether we have a good feeling about them or we feel very uncertain about them, I think we should test them. It should be included in the package so that the regulators don't feel like you haven't done that. That certainly would delay the timeline of the review. I don't know about the drug development progress, but you think about like 1 month of information requests to be addressed, that definitely delay the timeline. And that's something as an applicant you can try to do your best to, this is my intended purpose. And I believe within this model structure, be it, minimal PBPK or full PBPK, I believe, these are the 5 parameters I want to do sensitive analysis, and here are why. Now, going back to the global analysis, is that wouldn't that be, dependent on your fundamental model structure, not to mention, whether it's which platform, just like simple things such as full PBPK versus, minimal PBPK. I think the definition might be very different, right? If you do a global sensitive analysis, some analysis, the outcome might not be relevant. And I also agree that, Dr. Aaron said, when to do it is, you have a submission and here's your ultimate goal for DDI prediction. You put together this package. Within this package, you have a model development process, you have a validation process. Where does the sensitivity assessment fall into? So definitely you should include that, but like how do you structure this information in your package?
Thank you, Pin. It seems that some of us become sensitive to lack of coffee, so I want to announce a coffee break, 4:15, returning. Yes, thank you.